Going to take another look at the axial spine here. Let's start with primary versus secondary curves. I do want you to know this. When you're born, you basically have one big C-shaped curve, the fetal position. And as you go through growth and development, your spine is supposed to change shape. So this is very important that you allow the body, the child's body, to go through these different developmental stages. Once they start lifting the head, that will introduce what is now considered the secondary curve. Okay, the secondary curve is also known as a lordotic curve. Okay, so please know both. Lordotic curve. When the crawling and walking phase set in, you're also developing the secondary curve in the lumbar spine, also known as the lordotic curve. So the primary curve, also known as a kyphotic curve, is what you have at birth, the so-called fetal position, a big C-shaped curve. And then once you go through growth and development and your spine is starting to change shape, your neck and your low back now should develop the secondary curve, or the lordotic curve. The thoracic spine and the sacral spine keep their primary curve. So, in summary, cervical spine has a C-shaped curve, thoracic spine, kyphotic curve, lumbar spine, lordotic curve, and sacral spine, kyphotic. So there's sacrum, lumbar, thoracic, cervical. And this is a lateral view. Okay, the cervical spine has 7 bones, and we call them C1, C2, all the way to C7. The first 2 bones in your neck are the atlas and axis, so C1 and C2. Atlas is C1, axis is C2. Okay, so of the 7, 2 are considered atypical. And that is the C1 and C2 because they do not really look like the other bones. The other 5 cervical bones are considered typical because they all kind of look the same. C1 and C2 are the most important bones in your neck and your spine. The C1 vertebra is the first neck bone to receive the spinal cord. Okay, so just superior to the atlas is the foramen magnum, which is part of your occiput bone, and the brain stem is in there. So you have the brain stem, and then as the brain stem is exiting the skull through the foramen magnum, it turns into the spinal cord and goes all the way down the vertebral foramen, which are the big holes in the bone that go all the way down to lumbar. Okay, we'll look at that part in a little bit. So C1 is the first bone to receive the spinal cord. A lot of proprioceptive fibers are found there. It dictates the position of your head. Is your head on crooked? Is it sublexed? Is it rotated? If atlas is misaligned, translated, moved out of place, it causes a lot of postural disturbances, can cause headaches. Remember back to our article, if the spine goes out of place, adverse health, increased pain, increased pathologies, all that stuff start to set in. Okay, here is C1 or atlas. And there is your vertebral foramen. This is what receives the spinal cord, the first bone to receive the spinal cord. Okay, here's C2. And C2, as you from a superior view, also has a vertebral foramen. And all the vertebrae do. All the way down, all these foramen stacked up, 24 bones of these stacked up, create a canal. And your spinal cord travels down through the whole thing. C2 has a unique part called the dens or odontoid process. Things spin on an axis. So axis allows you to do the no action, and atlas allows you to do the yes action. Okay. So therefore, there's a lot of movement there. Now the rest of the bones, for the most part, look like this: C3 through 7, with the vertebral body, the transverse foramen, transverse process, the bifid, spinous process. Okay. And then over here, this is what a thoracic bone would look like. What makes them unique is their articular facet for the ribs. Okay, they do receive thoracic spine. You have 12 thoracic bones, 12 pair of ribs, and all those ribs attach to the thoracic spine. So the thoracic bones need a special articular surface to receive the ribs, and you're seeing it there. And that's also something we'll cover in lab as well. As you hold the actual thoracic bone, you'll be able to see the costal facets. That makes it distinct as a thoracic vertebra. And the lumbar is a big bone. It's a weight-bearing bone. Not that the others are not weight-bearing, of course they are, but your low back, a lot of biomechanical pressure there. It's a very big weight-bearing area. In fact, we'll look at some of those mechanically later on. We've got some really neat slides that show you what the kind of pressure and so forth that the lumbar spine experiences. So all these different parts that you're seeing, we're going to go over those in more detail in lab, but those will be some parts that you'll have to know. Okay, I just mentioned that earlier, so read through that. Also know that the atlas does articulate with the occipital condyles. So just superior to the atlas, you have the occiput bone, and they have these special parts on there called the condyles that actually connect to the atlas. And that's what allows you to have that yes action. Okay, these terms here, proprioceptors and mechanoreceptors, those are fancy terms for balance centers. We'll talk about balance and proprioception in more detail later. But for right now, as introducing new terms to you, do know that proprioception and mechanoreceptors are what help us with balance. Okay, there's a lot of feedback that goes to the brain that helps us with balance. Vision, inner ear, the cerebellum, the brain itself, Golgi tendon organ, muscle spindles, different fancy nerve stuff in our joints, and all this is giving us feedback to the brain to constantly keep us in balance. Okay, so your upper cervical spine has a lot of mechano and proprioceptors. So when it gets subluxed, when it moves out of place, you get these spasms, these muscular spasms to try to guard and protect, and that can contribute to headaches and limited range of motion, and other disturbances, musculoskeletal disturbances. Okay, there's that term, odontoid process. So the axis has a unique structure that makes it very identifiable. And that'll also be best seen in lab when you actually hold a C2 bone. You can see that odontoid process. Okay, the vertebral artery passes through C6 through C1 in the transverse foramen. Okay, so please write that down. Please know that the vertebral artery bilaterally passes through C6 through C1 in the transverse foramen. And in a fewer percentage of the population, it does go through C7 through C1, but most of us it's C6 through C1. And you're seeing a picture of it here. So that red is the vertebral artery, and if you look closely, it is passing through the holes that are in the transverse process. Now remember, a hole in bone is called a foramen, and because these holes are in the transverse process, they call it the transverse foramen. And the reason for transverse process is because it lies in the orientation of the transverse plane. And a process is anything that is a bony prominent or sticks out of bone, which that's something we'll cover later as well once we get into the bone nomenclature. Okay, here you're seeing a lateral view of C2, and you can see the odontoid process there. It's important for spinal or for head and neck stability. So a couple concerns. In fact, actually, we're going to add a third one here, and that would be trauma. Okay, trauma. The articulation between the dens and the atlas is a synovial joint. So there's synovial fluid, which means a person with rheumatoid arthritis can start to get some inflammatory responses and degeneration at the where the dens and atlas come together, which can over time lead to upper cervical instability. Another one is Down syndrome. There's a growth plate in youth, but sometimes that growth plate where the dens meets the body of C2 doesn't form properly, which means it's unstable. Okay, so flexion and extension of the head can create the actual bones to move excessively against the spinal cord, and that hurts, and it can be dangerous. And of course, trauma with head trauma, motor vehicle accidents, whiplash, getting banged around pretty hard, diving into a pool, and all that can break your upper cervical, including the dens, and lead to upper cervical instability. A video fluoroscopy x-ray or a stress x-ray where you're taking an x-ray with the head in different positions will verify this, and then that is typically a surgical repair, and very important that they get that fixed, otherwise you risk doing severe damage to the spinal cord. Okay, know your areas. The green part here is cervical, there's thoracic, there's lumbar, and then it's showing you the different orientations of bone, a superior and lateral view. And in lab, I'll go over how to identify a cervical, thoracic, and lumbar bone. I've already alluded to some of that in prior slides, but I just feel like if in lab, if you are able to hold a bone and see it, and we go through this together, it'll be more tangible for you. So save a lot of that for lab. Okay, your thoracic spine is T1 through T12, and it does receive the head of the ribs. The thoracic spine does have a lot of compensating subluxations there, and also rib subluxations. And rib subluxations, they hurt. It hurts to breathe. You got this ice pick, knife-like pain in a very specific part of your back. the deeper you try to inhale, the rib head, where it articulates with the costal facet, it gets jammed, creating joint inflammation, and it just hurts. So once the rib is put back into place, and then you do therapies that calm down the soft tissue, brand new body. Feels amazing. Also, osteoporosis in the thoracic spine can lead to a compression fracture. Keep in mind, osteoporosis is brittle bones, demineralization. So with the weight of the body, the thoracic spine can just collapse. So it's a common site for osteoporotic compression fractures. Okay, your lumbar spine is L1 through L5. A lot of mechanical stress does occur in the lumbar spine. In fact, some of those real human skeletons we have in lab have evidence of osteophytes and degeneration, which I'll show you when the time comes. Okay, a pars fracture is where you get a break in the pedicle. So there is a special part on the lumbar spine, the lumbar bone, called a pedicle, and that can break. So a pars fracture is something that you can see because of the stress. And then a spondylolisthesis is basically a forward slipping of the bone. So here's a sacrum. Okay, it's a lateral view. All right, here's L5, here's L4, and we have our disc space. Okay, there's L3. Okay, now and for slang, it's called a spondy. In a spondy, a vertebra will slip forward. Okay, so now here's the sacrum, and there's the slippage, and then the rest of the bone. So you're seeing that anterior slippage. That is called a spondylolisthesis or a spondy. Also, the low back, the lumbar spine, is a common area for herniations. This is where the nucleus pulposus and the disc will move posterior and lateral. That's very common for them to go posterior and lateral. And when that happens, it's very painful. You activate the sinovertebral nerve, pain fibers, press on nerve roots, causes lots of problems. Now, I treat a lot of herniations. I have a spinal decompression machine, which is fantastic for helping correct and treat herniations, and has about an 86% effective rate in avoiding surgery. So if you have about a 5 to 6 millimeter bulge or less, spinal decompression and PT and rehab therapies and so forth can really help you. Now, if you go immediately to an orthopedic surgeon, of course they're going to want to do surgery on you right away. So be an advocate for yourself, get a second opinion, get a third opinion, seek conservative management, because you may be able to correct the problem without surgery. Now, later we'll look at some research by one of my favorite spine orthopedic surgeons named Richard Deo, and he'll talk about how unsuccessful a lot of these surgeries, spine surgeries, are. Okay. Now, I get it. If you cross a line and you legitimately need spine surgery, then fine. Let's do that. But it's also worth visiting with someone who really does understand where that line is, and if you're below the surgery line and you don't need it and conservative management will help you, then it's worth doing that versus just going under the knife. And the $100 billion area means the low back does cause a lot of problems. People have missed work because of it. Lots of surgical procedures, therapies, PT, adjustments, medication, on and on it goes. All that added up is over $100 billion a year just in low back issues. And then when you look at the the data to what's going on, that's something we could talk about for forever. But really, the quick version and the most prominent thing is a lot of sitting. The more static the low back, the more you sit, the quicker it will degenerate and become arthritic and so forth. Of course, you have to throw in diet and lifestyle as well. What you're not eating can hurt you, and what you are eating can hurt you. There's pro-inflammatory foods that just are not giving you the micronutrients you need for healthy disc, healthy spine. So diet and lifestyle, and then to some degree some genetics, and then some other factors that might be out of your control, like trauma and other things. Anyway, all these add up to create some low back problems. Okay, the sacrum is formed from 5 fused vertebrae. Remember, when you're born, they're individual segments, and as you go through growth and development, they eventually fuse, as does the coccyx bone. Okay, this statement here, with directional terms, I am going to ask you some directional term questions on the test. So in the lab test, that one's pretty straightforward. Gross anatomy, bones on the table. The note card says, what's this? Just identify parts. In a lecture test, you have to identify bone parts through sentences, through wording. Okay, I'm going to ask you, like this one, if you're looking at the sacrum, what articulates superior to the sacrum? The answer is L5. What articulates inferior to the sacrum? And then that would be the coccyx. I'm going to ask a lot of questions like that on the lecture test. Okay, so make sure you know your directional terms, be able to visualize it, visualize and know these bones. If you can do that, you'll be able to answer these questions. Okay, the ala of the sacrum, ala means wing. So here's our sacrum. This area is considered the sacral ala, or ale, depending on pronunciation. And it articulates with the hip bones, the os coxa. And at that junction, it forms the sacroiliac joint, the SI joint. Okay, also we have holes in the sacrum. Those are the sacral foramen. And remember, foramen means a hole in bone is a foramen. And the purpose of them is so arteries, veins, and nerves can pass through. So the nerves exit through the sacral foramen. Okay, we also have a sacral canal and hiatus, and that is a distinct hole, a tunnel, I should say, that goes through the sacrum. When you hold the real sacrum or see a better picture, you'll see what I'm talking about. But do know that there's a sacral canal that goes down this way, and then the sacral hiatus. Your coccyx is 3 to 5 fused segments. It's the lowest part of the of your spine, and it is very painful when subluxed. A very common population to get a subluxed coccyx is expecting moms, so they're pregnant. Typically, you don't really start to see this until second trimester. I treat a lot of these. I've got a really nice pregnancy pillow, so they come in, lay down, and this part's kind of fun. Most moms, once their belly gets big, they haven't laid face down in a while, so they're laying on this pregnancy pillow that I have, and they're just going, "Oh, this feels so amazing," because it's been a while. So, but then we get to work on the coccyx and correct that, and tremendous relief, tremendous relief. And you don't have to be pregnant to have a subluxed coccyx, so this can happen to anyone.